Thanks for having me here. Actually, I was with Paul at a talk last week, so I'll share this story that I had. You're talking a little bit about situations and context, building a case. A few weeks ago, I was watching a Schwarzenegger movie. You could probably edit this out for the purposes of the video part, but I was watching a Schwarzenegger movie, his last one, and I thought about elder abuse. So Schwarzenegger and elder abuse, right? It has to be a great movie. The situation that had developed was there was an old farmer who delivered milk to the town on a regular basis that Schwarzenegger was a sheriff in, and the waitress at the diner astutely at 4:30 every morning. He normally delivers his milk by 4, but at 4:30 she grew concerned, and that context, that situation, that case was changing, and who does she call? She calls up Schwarzenegger, right? Turns out Schwarzenegger goes to investigate it. It turns out that the old farmer was killed for his land, and his land was taken so that the bad guys can use it in part of their plot development, right? So Schwarzenegger handles it not via DA prosecution, but rather he kills all the bad guys. So that's a different approach that I don't think that we'll be taking anytime soon, but that's the Schwarzenegger approach, and you terminate them, right? So with that, we could probably go on to the part that would actually be worth taping. Let's see here. So I have no disclosures. And today we're going to be talking, you probably heard some of this already throughout the morning and throughout the rest of the day, but I'll just try to recap to the best I can. Discussing the definitions, categories, as well as the impact, prevalence, and incidence of what we know about elder abuse and neglect. Also looking at different historical, physical signs of elder abuse and neglect. Again, those situations, those cases, that context that we're talking about. And then I'll talk a little bit about proper documentation and proper reporting procedures, but which you'll hear about later for San Diego County later on in the day through APS. So we'll share today what we know about elder abuse. Unfortunately, there's still a lot to be learned about elder abuse. And part of the problem with that, the reason why we know little, is because that there are a lot of barriers to elder abuse and detecting and reporting elder abuse and properly handling elder abuse. Here's a list of the different points regarding some of these barriers, but I think what it comes down to is that there is a lack of knowledge because of these barriers. There, like everything else, is a lack of resource and lack of time. But most importantly, I think that the attitudes that are out there, ageism, perspectives towards elder abuse and our elders, is probably one of the biggest problems. This is it's the example where we say that our patient is too old, too elderly, that because they're old, they have these certain conditions, that they have dementia, they're going to forget. Because they're older, they're going to fall. And this is something I see it with my patients every day in my geriatrics primary care practice. It's part of the health system, it's part of our attitudes that we're teaching, unfortunately. Here, this is a picture that we took from a case in the last, does it look green to you? And within the last year and a half, and this was a case where a 70-something-year-old who lived at home with her son presented to the emergency room with altered mental status. The patient was admitted for urosepsis, but didn't have her clothes changed until she actually got to the floor. And the nurse, so she went through the emergency room, got up to the medical floor, and the nurse changed her clothes. And this is what she found. Right? So there's feces there, there is urine, there's broken skin there. The important part, though, about this was actually, so in my hospital, in a lot of the hospitals in the area, obviously they're training sites, right? So there's a lot of students and residents and interns and nursing students and pharmacy students, not to mention all the different professionals that are there, right? So in this situation, the nurse had notified the attending physician taking care of this patient now after coming up from the emergency room. And when the attending physician saw this, he, in front of his medical students, had said, "That's just a hygiene problem," right? Do you really think that that's just a hygiene problem? That's the problem. Unfortunately, that message gets conveyed to the medical student, gets conveyed to the nursing students, and everybody else that's a professional, that it's okay to look at these folks, these patients, our elders, in this way. The nurse actually called the Dog Protective Services, and by the time APS came and the police came to investigate, the hospital floor was actually clapping because somebody decided to take a stand on that. So that's really the message that we should be getting across, not that it's just a hygiene problem. But this is a perfect example of what the barriers to care are out there. So I think you guys talked a little bit earlier about the growing population, getting older, and what our population has looked like. This is just another slide of many that's out there looking at what our population is doing. And you can see that our older folks that are 65 and older, I mean, that population is going to be doubling within the next 20 years or so, in large part due to the baby boomer population. So what does this population longevity mean? It actually means that as age increases, so do all the other health, social, and psychological issues that are there. We're going to see more chronic illness. We're going to see people on more medications. And we're going to see more incidents of and treating depression, dementia. There's going to be problems with providing the right social milieu for these folks that are getting older and maintaining good health. There's going to be, because of all these different issues, decreases in reserve. Because of this, it leads to vulnerability to abuse and adults. For adults, difficulty defending themselves, more likely to get injured. This is the iceberg theory of elder abuse that's been talked about, meaning that what we hear about, what's been reported, is on the surface, but there's probably a whole lot more cases that are unidentified and unreported beneath the surface there. I have some better numbers than this, but if you were to actually calculate out the unreported cases, it's believed, in general, one of the stats that's out there is that for every one case of elder abuse that's reported, there's probably 5 cases that are unreported. And so that number goes from 70,000, you add in the 378,000, so that's close to 500,000 in terms of new incidents of cases received by APS across the country. So I think you guys, Mr. Greenwood also gave some definitions about elder abuse. These are 2 that I took from the Penal Code and the National Center on Elder Abuse. And it's basically any knowing, intentional, or negligence act by a caregiver or any other person, paid or unpaid, that causes harm or serious risk to a vulnerable adult. PC 368 Penal Code is there for your reference. And in California, an elder is defined as anybody who's 65 and older. Dependent adults actually fall in this category too, so between the ages of 18 and 64, who have physical, mental limitations that restrict his or her ability to carry out normal activities or to protect his or her own rights, including but not limited to persons who have physical or developmental disabilities or whose physical or mental abilities have diminished because of age. So, in general, Mr. Greenwood had a question about just in terms of another state reporting a case. One of the issues is that the definitions for elder abuse, the different categories, is different depending on what you read. A little bit different between the different states also. In general, depending on what literature you're reading, there's going to be 8 classes of elder abuse, and it's going to fall under physical, sexual, neglect, self-neglect, emotional, financial, and then abandonment and abduction. So you guys have access to the slide, so these are the actual definitions of each type of abuse. The ones for the health providers that we typically will see if we're in the right context is the physical, as well as potential sexual, potential emotional. Families will tell us about financial. Again, paying attention to what context all this is in is important here, as well as neglect and self-neglect. This is an example where a sexual abuse case came to my attention, where it was actually an 81-year-old gentleman who had known cognitive impairments, and a hired caregiver performed sexual acts on the patient because the patient had supposedly requested for it. My involvement has also been with our forensic center in Orange County, and I'll explain what that is a little bit. So by as a part of that team, I was asked to do a capacity assessment. This gentleman had a MoCA, Montreal Cognitive Assessment score of 6 out of 30, so pretty low MMSE or mini mental status exam score as well. So he basically couldn't make any decisions regarding this. But the argument is that, well, he wanted it, and that's what prompted it. But still, if you're a hired caregiver, I don't know what prompts you to do that in this situation here. So obviously this case went to prosecution because of that too. So the other types of neglect or abuse that are out there, so I mentioned self-neglect, abandonment, isolation, restraints, which fall under physical abuse, and then abduction as well. So what do we know about the incidence and prevalence of elder abuse? Again, true numbers not known. I mentioned some of the difficulties, reluctance to admit, shame, fear of losing independence, kind of like what Mr. Greenwood said about that last case, that don't tell anybody, was what is out there. So from the National Elder Abuse Incidence Study from 1998, there was 236,000 reports of seniors abused at home in 1 year, and 50,000 abused within nursing homes. Our best estimates have it between 4 to 10% in terms of incidence and prevalence of elder abuse out there, 4% annually incidence-wise. But we really, truly don't know the exact numbers. But 4% to 10%, that's 1 out of 10 to 1 out of 20 people that are in home settings, normal community living settings. So those are, I think, are astonishing numbers. I think you guys are going to hear a little bit about who's mandated reporters and not. Physicians, health providers, people that are providing health care are mandated reporters, as well as, like Mr. Greenwood was saying, financial institutions, amongst others. However, less than 2% of APS reports are actually filed by physicians and health care providers. Majority are actually by other folks. So that's an important number that we need to educate our health staff on. Again, that statistic of for every 1 report of abuse, 5 go underreported. In California, that incidence, if you think about between 1997 and 2007, 10-year difference, the number of reports of abuse went from about 47,000 to 110,000 reported cases. So 110,000 in 2007 to APS in California. With that number, if you go 1 in 5, you multiply that 5, that's 550. So about 500,000 cases of elder abuse potentially in there. So the numbers are high. This is a breakdown of different types of elder abuse that are out there. Again, depending on what studies that you look at, there's some variation in these numbers. Physical, financial, neglect tend to be on the highest in terms of what's actually reported and seen. Somewhere between 30 to 50%, again, depending on the study you look at. This is, I don't know how well this is coming out, but this is just a number of cases in Orange County. In terms of the numbers going up, you could see that in 2000 it went from 4,500 up to about 7,500 cases reported in 10 years' time. So I mentioned a little bit about dependent adults. Little is truly known about the abuse of dependent adults, but we do think that based off of experts' opinions and research that is available out there, dependent adults 4 to 10 times higher risk of becoming victims of abuse, 10 times higher risk of becoming sexually assaulted, and they're less likely, like older folks, to report abuse. Lower rates of police follow-up and successful conviction of perpetrators. Okay, so the risk factors. This is Brooke Astor. She died in 2007. I don't know if you heard the story, but she is an heiress, philanthropist in New York who, big case involving her, where she is an heiress of one of the last original millionaires in America. And she was reported to live in squalor by her son. And well-known case of elder abuse. The reason why I put her picture up there is to, talk about the risk factors, really, and the abused. This is the profile of somebody who's typically abused from what we see. So over 80 years of age. Brooke Astor happened to be, I think, 104 or 105 when she passed away, though. So a little bit off of this risk this category here, but over 80 years, 2 to 3 times more likely to be abused. Majority are more female. There's some presence of cognitive impairment, dependent, having dementia. Physically aggressive or verbally abusive, meaning the symptoms that dementia or that person, that victim, may actually in turn have. So Ms. Astor, she was reported to have dementia at the time, and she was dependent for her care. I won't show you a picture of the abuser, but I think Mr. Greenwood probably painted that pretty well for you. But typically the abuser may have depressive symptoms, may have financial ties, may have had prior history of abuse present as well. And again, the context and the situation was what I had mentioned at the start, is really important to pay attention to. So people with mental health, substance abuse problems, that situation is a risk factor for elder abuse. People that have a higher feeling of stress, burden, being resentful, more likely to deal with elder abuse. People that are providing for care of an older adult who may have dementia, and that older adult may have a lot of verbal or physical symptoms. This puts you at a higher risk for an abuse situation. And then all the other things like financial, marital, employment, and the relationship between the older adult and the caregiver, those are all things that affect the situation and the context for abuse. So some special issues, adults with disabilities and dementia. In one study looking at folks that have dementia, and people with dementia, one of the things I said at the beginning in terms of barriers is that we think that, well, because they have dementia, they don't know what they're talking about, that they're not accurate, that they can't give a proper history. But that's not completely true. I see a lot of folks that have dementia, and I know that they can provide a history, even though it's not the full details. And it's enough to raise concerns and flags. In some studies that looked at folks that have dementia, looking at how often abuse occurs, the estimate may be as high as 47%. So that's a really high number for a lot of folks that have dementia that are out there. Physical abuse can be common, psychological abuse can be common, caregiver neglect. And also the long-term care facilities is another place that we have to pay attention to when we're talking about elder abuse. So for dementia, I won't go into the full details about it, but I see folks from a treating patient standpoint in terms of dementia. But the numbers that are out there, anywhere upwards of 50% when you're 85 and older, that can have dementia and Alzheimer's disease. And dementia clinically is characterized by memory loss, cognitive impairment, as well as functional loss because of that. There was this issue that I think Julian had mentioned to discuss what we know about undue influence. The definition of undue influence is the substitution of one person's will for the true desires of another. And it's excessive pressure, usually for financial gain in financial cases. We talked a little bit, or he heard a little bit about the lottery scams, families pressuring for money. This is a little bit different from coercion, which is another legal term that's out there. Coercion is when a threat is involved, violence is involved. We don't know all the details about undue influence. I think there's a lot to be learned. I think the scams are interesting that were brought up earlier, because we see that in folks that don't even have dementia in terms of being scammed. We see normal folks that may be susceptible to these scams. Being susceptible, the question is raised, is that related to this undue influence? Is there a part of the brain that does that? Some of the more recent literature and research that are coming out is actually saying that there are parts of the brain in the prefrontal cortex where, as you get older, it seems to atrophy or degenerate or not function as well, that are making folks susceptible even if they don't have dementia. So that's an area that's being looked at. What and how that's going to translate into medical and then legal situations, nobody knows right now. So what are the consequences of this? So I mean, you heard a little bit about financial, so income can be lost, savings are drained. Emotional, leading to feelings of self-worth not being there, depression, safety issues. The physical issues related to this, so compromising health, the cognitive issues. They actually did one study to look at after cases of elder abuse, are there higher incidences of dementia? And that may be the case. One argument in folks or as a risk factor for dementia and cognitive decline is that is potentially an abuse situation. Are you taking down some of your supports that you would normally use to prevent you from succumbing to the effects of dementia? So if you think about it, if you abuse somebody and then you take away all the things that they're dependent on, well, now they don't have that support system and they're going to fall and spiral down more. So those are some of the concerns that are being raised out there. Changes in family dynamics, other children, siblings, community safety, and social expectations are all some of the social consequences that are out there as well. This is a really long slide that you guys can just refer to in the PowerPoint, just looking at some of the numbers that are out there. I point out that I think the first point is probably the most I think astonishing in terms of the number, but elder financial abuse costs older Americans more than $2.6 billion per year. And that was through a MetLife study. So, I mean, that's just an astonishingly high number, and that was in 2009. And those numbers will probably grow. So, again, the consequences of elder abuse. So what are the patients? What are the victims? What do they feel? You know, I took this from some different campaigns that are out there in terms of elder justice. And some of the folks and victims this is what they're saying. You know, she picked me up at the hospital. I said, I'll be so glad to get home. And she said, you're not going home. I moved you in with me, was what one victim said. Another said, you don't want to get close to another person afterwards and call them your friend. You're afraid to. So these situations all prevent you from growing, even if you're 90 years old here. So that last person lost her home furniture, doesn't want to develop any more friends. So 90, and if you're perfectly functioning cognitively well, I mean, you still want to maintain those social friendships, all your things that keep you going. But now a 90-year-old's afraid of it, and you can just think about all the different consequences that this will lead to. So the first quote is from a person, from a woman who was abused by her partner. I thought our marital problems were all my fault. He had me so totally brainwashed and convinced that I was crazy, lazy, stupid, and worthless, that I was a walking zombie. And the last one was from an older woman who had been married. I spent every waking hour trying to be a better wife and mother, but the harder I tried, the worse I became. I mean, these are the things that people are feeling about themselves after they've been victims of abuse. So, again, it illustrates how important of a problem this is to our patients. So, the role of the healthcare provider and what to do and what to look for. Again, goes back to the barriers. So the barriers that I see that I think are the main ones are our attitudes, the lack of knowledge, lack of time, lack of resources, which is a lot. One question for the healthcare provider is, do we screen for elder abuse? And actually for this, the U.S. Preventive Services Task Force, and just recently, after their review, they don't recommend, or they found insufficient evidence to recommend screening for elder abuse. Whereas this is different from the child abuse literature. Part of the problem is that we don't have good tools that are out there to be able to sufficiently detect, and we don't know all the consequences of it either. So, some questions that can, you know, if you're in the right context and situation, again, some questions that can be asked that are helpful though are you afraid of anyone in your family? Has anyone close to you tried to hurt or harm you? Has anyone close to you called you names? Does someone in your family make you stay in bed or tell you that you're sick when you aren't? Has anyone forced you to do things that you didn't want to do? Has anyone taken things belonging to you with or without your okay? So these are questions that you can ask your patients. I think one of the questions that goes back to the barriers is that I get asked is that, well, is it okay to ask your patient or the person that you're working with directly these questions? And I think it's yes. I mean, nobody knows the correct answer to that, but it probably takes, again, that right situation and context. The concern is that, by asking such a question, you may be breaking your trust or breaking your relationship with your patient. You may be losing your patient. You may be losing your client. I think by asking that question, and I've asked this question plenty of times, and a lot of those patients are still my patients. The flip side, if it is that if you have some concerns in this context and you don't ask the question, they can go on to be abused, they can go on to lose their money, they can go on to have other morbidities that happen to them, they can go on to die. And so think about that if when we're talking about screening and asking for our elders and our patients about whether or not to ask these questions, even though all the guidelines say that it's not recommended or there's insufficient evidence to recommend it. Like I tell folks, in terms of picking that situation, Mr. Greenwood, he needs that case, he needs that context. So the same for us. If you're with your patient, look for clues in the patient that may make you think of abuse. So changes in your client, in your patient, in how they're presenting to you. Are they more flat? Are they more apathetic, less caring? Are they more hesitant? Are they more evasive? Are they more fearful? Are they more anxious? Are they more hostile? Are they more aggressive? Uncooperative, suspicious? I had one case who actually was my patient and not related to the forensic center that I participate at. And it was a patient who has dementia. She's Italian, so she speaks Italian and English. And in the time that I had always known her, she always spoke English. Her daughter had used a community agency for respite care for a little while. And by the time that she had picked her up afterwards, she only spoke Italian. So we couldn't figure out why this was the case. And when we saw her, we found, bruises that are in places that shouldn't be, right? And we ended up calling the agency or the place that she was at and trying to figure out what happened. But I ended up having to report it to APS because I think that some abuse happened, and it actually scared this lady so much who had dementia that she couldn't speak English anymore. A few weeks, a couple months later, she went back to speaking in English. So, that was represented an abrupt change. That was a clue to me that something different was happening. And again, that's, just because she was speaking Italian doesn't mean it's going to be abuse, right? But it was a change, and looking in the context of the situation, finding bruises where they shouldn't be, those are the things that caused us to call Adult Protective Services in this situation. So I'm going to go over some of these red flags or some of these other issues in a moment here, just summarize it. But look for injuries and red flags, things that shouldn't be there. And I think that's the take-home message. Bruises, fractures, pressure sores. These are all things that we're going to see. It's when it's not in the right context. Think about location. Think about the shape of what we're looking at. Think about more than one injury. When we talk about ulcers and sores, think about the various healing stages that may be there, or the different healing stages. If the explanation about how they got this injury doesn't fit the injury, then that can be a red flag, okay? If there's a delay seeking care, if somebody falls and they're coming in 2 weeks later with a broken jawbone, that seems like a really abnormal explanation, right? So there's a delay in seeking care there. So those circumstances, the events, look at the caregiver too sometimes. Pay attention to what they're doing. Are they different from what you're normally accustomed to? Are they concerned about what's going on? How are the interactions between your patient, your client, and that caregiver? So for us, for the healthcare providers, in terms of how we can help out Mr. Greenwood, is that we should try to take as accurate of a history as possible, because sometimes it will come back to our testimony in terms of what's going on, what's needed. Do a good physical exam. Do a good mental status exam when you can. When in the right context, the right situation, do a laboratory test if you need it. And then keep in mind those red flags. Ask open-ended questions. And you can proceed to more specific questions and try not to lead the victim, potential victim. If you have to, separate the victim from the caregiver. Keep in mind the cognitive ability and capacity. Again, we talk about folks that have dementia and whether or not their testimony, their history is reliable or not. And we do have folks that actually do have dementia that may have certain kinds of dementia where they may be very delusional too. So that's something else to keep in mind. And they may report elder abuse or abuse on everything. Just the touch of your hand to your hand to their hand, they may report elder abuse. So keep in mind that context is important. Clues on physical exam, we'll look at these in a moment here, but pressure sores, poor hygiene, unkempt appearance, poor foot care, low weight, weight loss, dehydration, the body language of the patient, like I was saying, types of injuries, bruises, fractures, burns, and then, like I said, what to look for. Location, is it consistent? Old injuries and the delay in seeking care. The mental status and capacity. It's difficult when we assess mental status in our offices in terms of having a perfect tool or perfect solution. When we talk about folks that have dementia or other mental cognitive problems. But what I think there's different ones out there, mini mental state exam, a mini cog, a 6-item screen, a Montreal cognitive assessment. I think the bottom line with all that, when you use it and it's appropriate, if there's a big change from what you know this patient, this victim, potential victim, this client of yours to be, I mean, that may give you information. And the clinician's role is really observe, provide opinion, and not make a specific diagnosis necessarily, because you suspect abuse, you report it, and then the authorities will come, and the proper folks will come and investigate that situation. So, don't take it upon yourself that, look, you have to be the one making the diagnosis. No, you leave that up to the right people for that job there. So, bruises. I hear this all the time that, because we see it when folks that are getting older, they bruise, right? And it's hard, bruises are common, it's hard to tell what's abuse and what's not. There's a lot of age-related changes, so changes in collagen, thickness of the subcutaneous tissue, where your blood vessels lie, medications that may make you more prone to bleeding when you do have an injury. Those are all some of the factors that complicate this topic about bruising. There's been discussion about whether or not you can tell if the color of a bruise can tell you exactly when it had happened. And I'll tell you that you can give an idea, but the numbers are not. The research out there is not really that supportive that you can be that accurate about it. They can be in multiple stages of healing. And then again, it goes back to context. Is it consistent with the injury and the location? So we did a bruising study, or UCI did a bruising study that was published back in 2009, looking at all the different bruises and looking at location and size and trying to get an estimate of, okay, are some bruises more common than others? They took 48 abused participants, and this is the numbers that they got. They got, let me see here. The red on green doesn't work very well, huh? But basically, the numbers that were inflicted in abuse cases, more prominent in the head, neck, and torso areas than compared to accidental bruises, okay? That's one number to look at. This is what, again, the colors, the red is actually purple. But the red/purple were all the cases that were known abuse cases and where the bruises would fall into. So in the head area, the neck area, the torso, upper extremities, again on the back side, head area, those are all more common sites for bruising for folks that were abused than kind of your run-of-the-mill average everyday bruises. The run-of-the-mill average everyday bruises are going to be more on the extremities, on the lateral surfaces, okay? And then when you look into the size of the bruises, when we say abuse or no abuse, the large bruises tend to be more signs of the physical abuse. Now, that's not always true. Again, it has to be in the right context. These were known cases of physical abuse, 48 cases, where by our definitions in the study said that they can be up to 25 centimeters in size. The smaller bruises happen to fall into the accidental bruising category. Again, the no abuse cases where there are accidental bruises, more likely to be on the extremities. So in this case, left arm, right arm. In this particular case, not the lateral surface, but on the arms. So when you compare these two here, which one is more likely to be accidental bruising in this situation here? A, B? A, right? Yeah, it's pretty close, right? It's one surface versus the other, but one side just looks different to you compared to the other. This on the B side may prompt me to ask, what happened? And that's the kind of case where somebody grabbed their arm really tightly and you're going to cause a bruise, okay? Whereas this may be what you typically hear about, I bumped into something here. Again, you think this is accidental or inflicted, right? So this is probably more likely to be accidental. It's on that shin surface, another place that I typically bruise when I bump into. What do you guys think about this one? This is, again, not showing up the red on green. This is actually, I cut off some of this picture here, but this is actually a leg, okay? And this is in the suprapelvic area, this bruise right here. So not a fall, right? This bruise actually extended all the way down into the vaginal area and into both thighs. In this particular case, we actually couldn't get any history on this client, on this victim, because the caregivers had actually been with the patient or the client 24 hours, and then all of a sudden one day they found these bruising here. The client is actually aphasic, so they can't give any history. So we have nothing in this particular circumstance to go over here in this situation. So really difficult when you're just dealing with bruises alone. Again, we don't have a context, but this is a bruise that I'm concerned about, that I think all of us in the room are concerned about, but we just don't know how to get at it without other supporting information. Mr. Greenwood doesn't know who to go after or what to go after in terms of trying to chase it down. Sometimes we hear about strangulation. The easy cases are going to be if you're going to see like a ligature mark or a hand mark on the neck, the upper chest area that shouldn't be there, finger marks. But some of the symptoms that you may hear in your office or see in your office are difficulty breathing or changes in voice, if their neck is more flexed and in this sniffing position. But ask questions about it. Obviously make sure it's not a medical emergency. Something that we may forget to look at is looking underneath the eyelids, looking for petechiae, which can be signs of strangulation. These right here. So it's something to think about. This is in a younger case to help illustrate it, but if you see these ligature marks or strangulation finger marks, something like that, it may, doing a full exam tells you to, hey, go look underneath the eyelids too, and ask the right questions. Fractures can be, I've broken some bones, can be accidental or abusive, right? There are medical conditions that make you more, I think we know, more susceptible to having fractures, osteoporosis, different kinds of cancer. Many different kinds of fracture out there. You can break different bones, right? But when you think about it, your older adult who may break a bone, who says that they fell, right? They fall. If you fall and you're conscious, you're going to fall on your arms outstretched, right? Or you may fall backwards on your hip or your bottom. So those are the bones that you typically are going to break. Your wrist bones, your hip bones, maybe your spinal bones. You're not going to break a jawbone, or other parts, upper humerus, something like that necessarily. So again, the context is something to think about that would make you suspicious. By that same token, I think there's going to be a dental talk later today. Jaw fractures is one thing. So if you fall and you fall kind of on your chin, you don't necessarily break the body, the angle of the jaw. I mean, this would make you more suspicious too in the right kind of context. This is where the fracture is in this particular case here. I just took this for an example, but there's a case that I'm working with where a person has actually bilateral fractures in the jaw, as well as a facial fracture in the sinuses. So that context, her reported story was that she fell. Her initial story was that she was hit. She changed her mind later, just like in Mr. Greenwood's case, because she didn't want the son to go to jail for it. But, think about the context which you're in. So, in general, burns for folks that are over the age of 65, twice the national average rate of death due to burns, but can be seen in physical abuse, neglect, self-neglect. Some things that we look for, like cigarette burns, things like that shouldn't be there. Not a lot of studies that say which is abuse or neglect or not. I mean, we just don't have enough data or enough evidence looking into it yet. Pressure sores. We all know that pressure sores can be common, right? If you have a lot of medical conditions, poor nutrition, poor hydration status, prolonged hospital stays, a lot of different scenarios can lead to problems with pressure sores. Pressure sores, however, are often preventable and they're treatable. Again, the context, what's the other stuff surrounding this pressure sore that makes you suspicious is the issue that arises. Is it been 3 weeks that's been reported for this pressure sore and nobody's looked at it, Those are the things I think about. The experts, when they do testify about pressure sores, they talk about the situation that client is going to be in. Is it a high-risk situation for that victim? If it's a typical pressure sore, is it one or are there more than one? Usually if you're sitting on the bottom, I mean, you probably get a pressure sore on your bottom. You're not going to get one necessarily on your back, higher, or in your ear, or some other place that we've seen before. And then the experts will typically take a look at, was the treatment proper? Were they getting the right care? We talk about laboratory tests. Oftentimes, as a physician, sometimes we have nothing to do other than to check blood work, right? But some things that can be important are looking at things that look for malnutrition, dehydration, changes in medication levels, so seizure medicines. Somebody's being neglected and not getting their medications and they have a history of a seizure disorder. It's good to check a seizure, like a Dilantin level, to make sure that they're getting their medications if you're suspicious. But again, it's in the right context or not. Sometimes we'll look at for malnutrition, dehydration, if you think that if they say that they've fallen or you're worried about neglect, leaving somebody on the floor, checking a CPK may be valuable. So these are all things that we should use judiciously in the right situation and context. Medications can be overused or underused. So medications that a patient or a client or a potential victim that they're supposed to be getting, they may be getting too much of to sedate them. We've heard that with Benadryl and other over-the-counter medications. Underused, so somebody with Parkinson's, I once heard of a case, I didn't get involved with this one, was that to prevent the patient from the victim from getting up, who had Parkinson's disease, they would actually not give them their Sinemet so that they would be less mobile, So those are all the stories that are out there. So other red flags and clues to look for. Bruising, again, like I said, where it shouldn't be. Bruising of the breast or in the genital area. Usually not a common site to bruise if you fall, right? So those are things that will raise a flag. Unexplained sexually transmitted diseases. So in somebody who's not mobile in the nursing home who gets a STD, I mean, that's got to be a problem right there, right? That's something to look more into. And again, I said looking at the patient, looking at your client and your victim, Are there big changes in the way they're presenting themselves? Are they more withdrawn? Are they more evasive? Are they more hostile? Neglect, we talked a little bit about the medication. Sometimes they take away their walker or their cane so that they can't walk also. That may be a red flag. So, and somebody that I know that normally comes in a cane, I usually ask them where their cane is if they come in all of a sudden and they're not using their cane anymore. Financial, they're not getting their medications. Are they dressing? Are they getting cleansed appropriately as related to that? Looking at the caregiver, majority of the caregivers, I think you guys will probably get some talk about too, but majority of caregivers are for our older folks or adult children and their partners and siblings. You look at them, you look for clues on speech, the way they're talking, the way they're standing, are they more concerned, are they more protective, are they answering questions and not giving your client, your patient, your potential victim a chance to speak for themselves? Are they being hostile or surly? So proper documentation. I have to review a lot of cases of elder abuse or suspected elder abuse. I think one of the problems with proper documentation is that with the advent and the implementation of electronic medical records these days, you tend to see things just kind of get copied and pasted over and over, which is not good for other reasons, and Medicare, et cetera, on there. But by doing so, I think a lot of folks are not documenting or failing to document all the pertinent findings that need to be. The things that Mr. Greenwood and the authorities are going to need they're going to need to know date, time, the proper identifying information. If you can, get the statements appropriate in there. Again, you're not making the diagnosis. You're going to be referring to Adult Protective Services or the authorities in the circumstances. But what may end up happening is that they may use your medical records. The pertinent physical exam findings, I mean, all too often I'll tell you that I've reviewed cases where there's huge decubitus ulcers and the skin is intact is the finding that I see on the notes. I can't tell you how many times I see that, but it does. And I have photos to prove that the skin is not intact. Right? So, talk about what your opinion could be about and what your concerns are, what you're going to do, treatment record and follow-up and referral plans, and that's usually if you're going to call APS or not. Making sure that you fulfill your requirements. So in California, this is just a brief slide. Again, like I said, I'm sure you guys will get more info on it. Health practitioners are mandated reporters. There is a legal protection to the reporter. It's usually anonymous. Your name is not disclosed. And I've had situations where I've had patients in my office, and I tell them, look, this is very concerning to me. I tell the kids too, this is a very concerning situation. I'm going to have to make a report. And a lot of times, that report is I tell them that it's there to help us figure out what's going on. And I don't necessarily lose my patients because of that. That's again going back to that concern. So usually the way it works is that make a telephone call when possible. Mr. Greenwood gave that number, the 858-55. 800-510-2020. So that's for San Diego County, 800-510-2020, APS. But call when possible. File the written report, the SOC 341, within 2 days. Financial institutions are another mandated reporter now. They weren't before. And again, this is different for different states too. That's the other thing to keep in mind. A failure to report can lead to a fine, jail time, both sometimes. What happens after the report? I think, again, in the afternoon, APS is going to talk a little bit about it. But I work closely with APS, so I kind of know what they do, too. APS, they'll make the appropriate cross-reporting to the different agencies, to in-home support services if needed, to police if needed. I think the thing about APS is that we think of them as this authority that's going to take people out of their homes, and the patients and the family members think that they're going to take away my mom or something, but it's really not. I mean, they're really there to provide help and help investigate what's going on and provide the right support and services. They may contact a long-term care ombudsman if the person is in a facility, family caregiver alliances, law enforcement agencies, help with planning if needed. Things like Meals on Wheels, adult day health cares, senior centers, support groups, mental health agencies in the county, home equipment services. So a variety of stuff that APS can do. They may have to recommend conservatorship in the right situations. They can call the police. They can't enter the house without the client, the potential victim, letting them in. And they may request a 5150 evaluation in the right circumstances. They may arrange for case management. So what APS may not do, as it stands now, is enter the home without permission. They can't remove a person against their will or force a client to accept the services. So I hear that, from my patients that, look, they're going to take me away if we call APS, but that's not true. That is a myth that's out there. So my experience with this has been, just to tell you, I know Mr. Greenwood is part of an elder abuse department division task force here in San Diego. In Orange County, we actually have a forensic center for elder abuse too, where it's an interdisciplinary team. These are all the different folks that we work with. We have physicians that work as part of this IDT team. The district attorney is there at these meetings. We have law enforcement, the different sheriff's departments come, APS comes, long-term care ombudsman folks can come, the public guardian can come, human options. So a lot of different parts of our team meet to review cases that are too difficult or too extensive. The APS alone may not be able to come up with ideas in terms of how to treat. We've been around for about 10 years. We're coming up to our 1,000th case of these complicated cases now. And so every week we see about 2 or 3 new cases of it that we review. In our calendar year in 2011, we assisted with 78 new cases of elder abuse during that year. And we have, as part of that, we have a vulnerable adult specialist team so what we do is, as a physician or a geriatrician in this, I may go into the home and do a medical assessment if the victim will let me. We also have a neuropsychologist who may do a psychological evaluation there if needed. We can do medical record reviews and other consultations as well. And so with that, I leave these questions for us. I think these are the important ones to be asking ourselves. With this elder abuse being a growing problem the way it is, and all the work that we still need to do and learn about this, we need to ask ourselves, what's our responsibility as a society to our older patients, our older folks, as this grows? What role should the government do? And what policies can we develop to help prevent this? Can we unite, really? Because one of the things about the different states is that every state has a different reporting policy. And I've had folks I know folks that call from other states into our local APSs, and it's kind of like a cross report that happens too. So we've done that with Texas also. And doing more research in this area, finding those markers, helping set up that context and trying to standardize some of these things. So with that, I think I'm about 10 minutes early, right? This is our website for the Center on Elder Abuse. Will lead you to the National Center on Elder Abuse. One other point, coming up on June 15 is World Elder Abuse Day. So a lot of different chapters around are going to be having different celebrations. As part of the process to try to unite, if you think about it too, is that we, as a whole, have to group together and make a stand on this. Mr. Greenwood last week at our talk had mentioned about Mothers Against Drunk Driving, right? You would never not take a case against drunk driving because you have a lot of people upset about drunk driving if that were the case. So you have a whole alliance, a following for that. So a social justice movement, right? So if that may be one of the things that it takes to help get this thing kind of untracked as well. So think about that. We've been trying to put together something called Ageless Alliance, but this website can link you to all those things. If you need more resources, information, it's all there. Any questions? We have about 10 minutes.
Yeah, I've heard that caregivers, family caregivers, for example, actually are on more meds than the patients they're looking after sometimes, simply because of the stress. So where would you see as a physician the opportunity to actually question the caregiver, supposing they bring an elderly person to a visit, so that you can assess them for excessive stress and so on that might lead to physical abuse?
Yeah, so the question was that a lot of times as a physician, our patients, the people that take care of our patients, may have a lot of medical problems, may be on a lot of medications, and you may suspect something, and the question becomes, well, when can you assess them, right? And I think that's a good question. It's a field or area that we struggle with, I think. I don't think there's a right answer to that. I think the issue is that if you have a concern that's raised, that you can give them, you are treating your patient, so you can't technically treat the son or the sibling or the caregiver, unfortunately, unless they're coming to you and establishing as a patient, and then you're talk about it. You can say to them, look, I know you can be honest with them and say, look, you appear very stressed. I understand that handling your mother who has dementia and can be verbally abusive is very stressful too. These are some resources that I can refer you to if this were to happen. If there are more warning signs than that, obviously you have to take the appropriate action. That's probably one of the best things that you can do right now, is just recognizing that they may be under the stress, acknowledging that and giving them that feedback. We do look at that kind of stress as a potential risk factor for abuse. And a lot of research is going on. We actually have a grant to look at, can we develop a model, a mechanism to identify that kind of stress, and what intervention can we make? But obviously the limitations are, they're not your patients. So that's some of the things that we have to circumvent too. So I don't have a right answer for you, but some of the questions that you can ask back to that caregiver to see where to go. And sometimes maybe it's offering them respite for your client. Those are the different kind of things. So.
Yeah, that's what I wanted to mention, like, you ask for respite.
Yeah, so the different resources, so.
Yeah, like, I have a client that we do only 10 hours every month, every Saturday. Because my client said, I need to get out of the house. I just do my mom, kids, husband, job. So every, once a month, on Saturday, she would work 10 hours. And she brings us just the whole brain. She said, I feel like, when I come back, I feel like I want to see my mom again.
Yeah, I mean, a lot of times in geriatrics in our practice, we get that situation where, your patient may not be that violent or anything at all. They just may repeat themselves a lot, and it's really frustrating for that caregiver. They may not be on any medications. And sometimes what we do is just offer them resources that they can contact. Maybe putting that patient in adult day health is beneficial for them in that situation. So there's no right answer. I think it's identifying some of these things.
Is there any sort of movement within the AMA and large medical practices to increase? The slide that stuck out to me was the 2% of reported cases are from physicians.
Yeah.
To me, that's embarrassing, perfectly honest.
Yeah.
What is being done within the AMA and large medical professionals to change that?
I mean, I think the thing that we're trying to do, I don't know personally within the AMA itself, is that for those of us that are trying to push this concept of identifying and trying to prevent elder abuse, we're, getting more training involved. Those are the things that we're trying to push those agencies and the groups to tackle. The problem is that as a physician, you don't get reimbursed for screening for elder abuse. You don't have the time, you don't have the resources. Those are all the things. So the bigger thing at hand is going above what can the AMA do at the governmental level, the public policy level, at the Medicare level, to give people the proper resources for that. So that's where that push is really. I don't know where we can do on an individual basis other than really training, going back to the medical school.
Are you presenting this to primary care physicians?
That slide, yeah, those are things that we're trying to, teach folks out there, and not just physicians, but obviously dentists and all different kinds of healthcare providers too.
There's no law to say that you can't give someone who accompanies an elderly person to your office a brochure or that talks about the vicissitudes of being a caregiver 24 hours a day, giving them help that way. And maybe they could find their own way to suggest sources for help and assistance.
Yeah, so the follow-up question was, and really a statement, is that there's nothing that prevents you from giving information or resources to the caregiver, because a lot of times we have to give that caregiver education on how to care for our patient, you know. Okay. I think there was, no? Any other questions?
At what point do you refer a patient, or does a patient move from, let's say, a GP or an internist to a geriatric person? Why would they do that, or how? What point does that take place? Specific, what? Can you say a word about that?
Yeah, I mean, I think, so the question is, at what point does a patient move from a general practitioner, family medicine maybe, over to this realm of geriatrics, right? I think that's a bigger question than all of it. I think the issue is that there's not enough geriatricians. We all know that, in terms of all the medical reports that are coming out about the number of geriatricians that it would take to take care of all the folks that are getting older. There's just not enough of a workforce for that, right? There's probably a lot of different ways to answer that. From a patient standpoint, sometimes patients aren't happy with this concept of ageism in healthcare, and all of our medical studies and all the resources. Look, you screen and you do this up until a certain age, and then nobody knows what happens thereafter, right? If the patients aren't happy, sometimes those are the folks that come to us in our practice. And our practice is strictly a geriatric practice, so that may be a reason. Sometimes folks are referring or transferring patients over to us from the physician level when they can't, when there's just too many different issues that are in play also. What we have at our particular site is that we also have social worker, other resources that are there that may be beneficial. So sometimes they're seeking that piece of it. So there's not a true correct point for that transition point. But from a patient side, sometimes they're not happy with kind of your healthcare as it stands now until it evolves farther, and they're looking for more. And from a physician's side, it may be that they need more services or help.